Okay, it looks like it's top of the hour. Thank you everyone for joining us today for our webinar. Just a couple quick things before we get started. Feel free to submit any of your questions via the questions panel throughout the webinar, and we'll try to get to those at the end. And your certificates will be available this Friday by logging into your account. Dr. Weingard and Amanda, if you're ready to get started, go right ahead.
Sure. Thank you guys so much for inviting us to come and give this talk, and thank you so much to all the people in the meeting that chose to take time out of their day to join us today. Amanda and I are very, very passionate about this topic, and so we definitely appreciate your interest. So today we're going to be talking about the human connection within perinatal palliative care. And just as an introduction, my name is Billy Weingard. I am trained as a pediatric palliative care doctor. I work for both Hospice of the Valley as well as Phoenix Children's Hospital. And I'm the lead for our perinatal program at through both organizations.
And I'm Amanda Butner. I'm the team leader for Hospice of the Valley and oversee the operations of our hospice program, perinatal program, and pediatric palliative care, as well as our Ryan House respite program.
And Amanda doesn't give herself enough credit. She is the heart and soul of our organization. We don't have any disclosures. Okay. So we always start this talk with this disclaimer. This information can be very difficult to hear. It's very difficult to think about, you know, the idea of a family having a child with a serious illness where they might lose that child. You know, it just is unfathomable. But you know, it makes me think of this quote from this book by Atul Gawande, from the book Being Mortal. Sometimes, oops, sorry about that. Sometimes we can offer a cure, sometimes only a salve, sometimes not even that. But whatever we can offer, our interventions and the risk and sacrifices they entail are justified only if they serve the larger aims of the person's life. When we forget that, the suffering we inflict can be barbaric. When we remember it, the good we can do can be breathtaking. I hope at the end of this talk you agree with this statement.
So we just want to start off with talking about a family that was very near and dear to us, and just kind of go over this and have you guys keep this in your mind while we're going through this presentation. So baby Edward, that's our little one that we were able to meet the parents for. Mom was a 28-year-old Native American woman who was pregnant with a baby who was found to have trisomy 18. And with trisomy 18, they can have a wide variety of different genetic issues, but with this, the primary issues were heart and brain malformations. The parents made the decision to continue their pregnancy with the intention of pursuing comfort-focused care following delivery, and they were referred to our perinatal program. So if you can remember that through our discussion, and then we're going to circle back to that towards the end.
Yeah.
So our objectives for this webinar are to state the reasons for perinatal palliative care, list some of the diagnoses that may lead to perinatal palliative care decisions, describe the process of decision-making in perinatal palliative care, list the ways to help families make memories with their babies, unborn or born, list ways to provide care to the family as a whole, and then identify resources for perinatal palliative care around the country. And then, of course, make you all champions of palliative care. So why do we care? You know, perinatal palliative care is a newer idea than a lot of medicine. The first practice of perinatal palliative care came about 20 years ago. And before this, there wasn't as much resources for families that might have a baby that was going to be born with a diagnosis like trisomy 18 or a diagnosis that may be considered life-limiting. Billy has a story that she can share about a family that she met.
Yeah, so in my clinic, a family had been referred. They had a baby affected by a condition that they actually had an older child that also had that condition. They knew from their experience that after their baby was born, that she would only have just a very brief time with them, which had been their experience with their first baby. And so we met and we talked about their hopes and their goals and, you know, what they wanted that time to look at. And at the end of our conversation, Mom shared, you know, that with their older child, nobody had that conversation with them. Nobody had talked about different options that they had. So after that baby was born and passed, he stayed in the room with them, but he stayed in his bassinet in a corner. She didn't know that she could take that time to really be a mom to him, to hold him, to cuddle him, to give him a bath, to, you know, dress his body. And she, at the end of our conversation, talked about that, you know, what a different experience this, it was going to be with their daughter versus their son, because now she knew that all of these things were options for her.
So that can be just to give you an idea of how new that idea really is of perinatal palliative care. And the American College of Obstetricians and Gynecologists endorses perinatal palliative care as well. So, but why should we really care? So I think that this is a very shocking fact, and I think it resonates probably with anybody. So if you were to fill planes with the babies that are born with birth defects, you would be able to fill about 536 planes every single year. So just that's the magnitude of, you know, the birth defects that we truly see. I mean, we think about a plane going down and it being this national tragedy, and this happens with families a lot. So in the US, more than 20,000 infants die every single year. Infants less than 1 year old have the highest mortality rate, and about 65% of these are in that neonatal period, which is that first 28 days of life. Our most common causes are chromosomal abnormalities and congenital malformations. So about 1 in every 33 babies are born with a birth defect, which equals about 120,000 babies per year. So just kind of a quick run through of some of the ones that we see primarily in our practice. So anencephaly, which is caused by a neural tube defect. This results in an underdeveloped brain and incomplete skull. Sometimes these children or these babies don't live to pregnancy or even survive delivery. If they are to live past that, they typically last about a couple hours to a couple days. And that happens in about 1 in 4,600 cases. And then we have severe microcephaly, and that is caused by problems during brain development. So this can happen with drugs, alcohol. Another thing that we see often is infection. So mom's pregnant and she catches an infection like cytomegalovirus. This can actually cause the baby to have a very small brain, which is considered a life-limiting illness as well. And this is about 1 in 1,400 births. And then we have our congenital heart defects. And this is, we're really looking at single ventricles, which is either hypoplastic left heart or hypoplastic right heart. So if you see where it says 25% of these are critical, we look at that critical stage being the first year of life. So the first year of these babies being alive, they're either needing a high-risk procedure or a surgical procedure to live. So about 1 in 100 births we will see that in. And then trisomy 18, like we spoke about with baby Edward, that's about 1 in 3,300 births, and that can be an array of different signs that we see. It could be underdeveloped brain, it could be single ventricle heart. We see quite an array of things with that. So typically, when we see these is about a 20-week ultrasound. So that is when typically we're hearing from the MFMs or the OBs that are saying, we would really like for you to meet with these families. You know, they've been given this diagnosis, and just trying to see, you know, what their wishes are, what their goals would be.
Okay. So this is quite a journey for these families. Most families that we meet in our clinics, you know, the moment that they found out that they were pregnant, there was just great joy. They're picturing their child growing up, graduating from high school, getting married, graduating from college. They're imagining the grandchildren that they're going to be able to have and love on. And so then they go for the anatomy scan, which is typically also when they find out the gender of their baby. And maybe the ultrasound tech is just spending a lot of time in a certain area. Or, you know, at the beginning of the scan, there was lots of happiness and joking, and then all of a sudden, it gets to be much more somber or much more serious, or the tech jumps up and runs out of the room. And this is quite bewildering to these families. And then, you know, when they do get to meet with the doctor shares with them that, you know, unfortunately, we've found some things that are not normal on the scan. And, you know, again, at a 20-week ultrasound, they're getting this news. And a lot of times they're being asked, well, what do you want to do with this situation? They're presenting options like termination or continuing the pregnancy. And, you know, unfortunately, telling the family that we need an answer, you know, right now or within the next week so that we can help support you in identifying, you know, what are the next steps. So oftentimes, again, this family went from this place of hope and joy and being very future focused to now having the rug pulled out from underneath them, and they don't even know how to think about these decisions. How does a family make these choices? So perinatal palliative care is an extra layer of support for parents as they navigate this. You know, we sit down with them and talk with them about what is most important to them for their family and their baby, and give them some framework and support in making those very hard decisions. So just to bring it back to palliative care in general, so palliative care is an extra layer of support in pediatrics to kids and families when they're faced with complex medical conditions that are potentially life-limiting. We facilitate informed decision by patients, families, and healthcare professionals. We all want to work as a team together to support families in that decision making. You know, I often say in palliative care that we want the family's goals to direct the care and recommendations that we make. We also assist with ongoing coordination of care among clinicians. You know, with these families, especially if there are, you know, in the case of like, you know, baby Edward, where he had things going on with his brain, he had things going on with his heart, he had a genetic condition. Well, they were seeing multiple specialists, and sometimes what those specialists say matches, and sometimes it really doesn't. You know, you have Dr. A telling you this, you have Dr. B telling you that. You're not even sure Dr. C is talking about your baby. So we can help bring all of that together and help parents to see how all of those different pieces fit together to make the bigger puzzle. So perinatal palliative care is really focused on maximizing quality of life and comfort for newborns with conditions that are considered to be life-limiting in early infancy. So, it's not that we necessarily expect that baby will not survive to delivery or that baby may only live for the briefest of moments or hours. Sometimes these kids, we expect that they may live for months to years even, but in supporting their survival, families are going to be facing a lot of different decisions, and so we can just help them and support them through that. So we also, in that want to focus on reducing suffering and honoring family values. So palliative care really, again, a lot of times it is presented as, well, we're going to do the things or we're going to just focus on comfort. Well, we in palliative care will always say we can provide our support along with those life prolonging treatments. Again, focusing on relieving suffering, improving quality of life, finding out from the family, well, what does that even mean to them? Because it can mean so many different things to different families. We can facilitate that informed decision making and assist in care coordination. So when should perinatal palliative care start? Like with baby Edward, as soon as the family found out the diagnosis, the team was saying, we have some folks that we think it would be important for you to meet. So really, we like to meet them from the time of diagnosis. And we will continue to support them through the rest of the pregnancy and after the baby is born. It should really be considered when there are fetal conditions that are identified that may lead to a miscarriage or death in the first hours, days, weeks of life. For some, it may be surprising to, well, why would you want to meet with them if you're expecting that the pregnancy may end in a miscarriage? But again, a palliative care team is unique in that we provide an interdisciplinary team to support them. So maybe it's not the physician that is the most helpful, but it might be our bereavement coordinator. It might be our chaplain. It might be the nurse who just has a very special connection with this family. Perinatal palliative care should also be considered when there's severe morbidity. The baby's life will not be a typical life. And so, we have to talk about, well, what does that mean, or how does that inform families' goals? If there's an extremely poor quality of life or suffering without a cure. When there are multiple management options, again, termination of the pregnancy, continuing the pregnancy with the intent to treat, so to pursue surgeries or interventions, hospitalizations, or to continue with the intent to provide comfort care, to make sure that the time with their baby is as natural and as comfortable as we possibly can make it. So we talk with them about which of these choices is consistent with their values. And we also talk about, at what point are we doing things to their baby versus for their baby. And unfortunately, most of the time that decision or that judgment is based with the family. So parental decision making is very complex. I think historically, it's often been presented as, will your baby live or will your baby die? And if your baby will live, will your baby have a normal life or will there be challenges? But parents' goals are much more complex than that. They're not just thinking about, will my baby live or will my baby die? They want to know, will my baby have a good life? Will my baby be happy? Will my baby suffer? And how will this affect our family? What does this mean for our family?
So these are a couple quotes from families that we've had. So I just wanted to let you guys take a minute or two and just kind of read those.
Mm-hmm. I think the bottom one is so profound in that you know, it's not about waiting for death, but it really is about celebrating the life that is.
So goals of a perinatal palliative care visit. So, you know, first and foremost, we want to establish and support understanding of their baby's condition. Mm-hmm. So we receive referrals from a variety of hospitals, OBs, MFMs, and we meet families that may know everything, you know, about their child's illness. And we meet families that are thinking that, you know, they might just end up in a wheelchair, or they might have, you know, they don't know entirely what that baby's life might look like with the advanced technology, or what a trach would be like, or what a ventilator would be like. So really peeling back, that's really where we go to first, is really saying, what do you understand about what's going on with your baby, you know, and getting to know them in that way. And then meeting families where they are. So that's a term that we use a lot in our line of work. Is it's really hard to talk with a family if they are in a place of, you know, we want to do everything, we want to do aggressive treatment, and then we're here to support that. You know, our goal is never to sway somebody into choosing comfort care versus aggressive care, but really just supporting them on whatever they choose. So whatever that looks like for them. And the next is discuss and establish goals of care. This has been especially helpful. I know a lot of folks on this webinar are, you know, in acute care and are in healthcare settings. So we've all been, our lives have been turned upside down by the COVID-19 pandemic. So really talking about establishing goals of care with hopes and fears and what are most important to these families. We see hopes as being, I want my baby to live, but if my baby can't live, I want them to be comfortable, or I want to make sure that we get a picture together, or, you know, fears are saying, maybe it's that they want to have a vaginal birth, but they, you know, we might have to do a C-section. So, you know, talking about those fears and really peeling them back and making sure that that family feels comfortable moving forward with it, whatever decision that they truly decide. And then focusing on what's most important. So what we've been able to do is within our birth plans is really talk about making exceptions. So for our families that have chosen comfort, is how do we make this go well for them? How do we make this, if this baby is going to live for 3 minutes or 3 hours and mom doesn't make it to discharge to get home, what can we do? So we really go to the hospitals and say, can we get siblings in? Can we get extended family in? Can we get Now I Lay Me Down to Sleep in, which is a national organization of photographers that donate their time that can go in and take photos as a family as a whole. So really, this has been especially helpful during the pandemic, and really feeling like we can support these families, even if they never make it onto hospice or they never make it home, really helping them get those people where they need to be so they can meet their baby.
I think another thing that we do is we, you know, families' goals and what is important to them in the time that they have, it's so highly variable that a lot of time what we do is just help them to see and realize that the things that they want are normal and appropriate, and that, you know, like we met a family that the baby was affected by anencephaly. And one of the things that was very important to mom was that she actually wanted to guide her baby's body out of her body. She didn't want the doctor. She didn't want, and so just helping them to say, you know, that's perfectly appropriate. And let's work with the delivery hospital to make sure that that is honored.
Absolutely. And then determine our needs for emotional support. So really figuring out where they are in their journey of what kind of supports they need. So we're able to provide a bereavement coordinator, and she's amazing. And we usually introduce her when we are introduced to the families, because we've seen that if Erica, our family support counselor, meets families with us, and while mom is still pregnant with baby, that she is able to support them following that baby's death, or even on hospice, or if they choose aggressive care, certainly our palliative care program. So that's really wonderful too, so that they have that support as well. So perinatal palliative care team and our partners. So we kind of mimicked this first little area as our team plus teams at the hospital. So our palliative care team, as well as most hospital palliative care teams, include physicians, nurses, bereavement or family support counselors, and psychologists. So really just a full team to really wrap our arms around these patients and their families, and trying to help them on every single level. Social workers help out immensely with what kind of resources can we get for you. Mental health is, hey, how are you doing emotionally? And then our medical team is really saying, how can we support you in the way of how do you want this to go, or how can we honor your wishes? And then we also have our pediatric and fetal specialists. So those are our partners. So in our other hospitals, so say we have a baby that's going to be like baby Edward, being born with trisomy 18, very well they could have met with pediatric cardiology or cardiothoracic surgery, as well as pediatric neurosurgery. And it's not just seen as meeting with the neonatologist. So sometimes we'll see that. Then we have our OB providers, including our MFMs, our referring hospitals, which I mentioned, and then organ procurement organizations. So really with donor network, sometimes our families want to build a legacy for their child in that way, where after that baby passes, that they can donate tissues or organs or eyes, and sometimes even mom will want to donate their placenta for ongoing medical research. So just some things to think about. And then we also have our milk banks. So sometimes mom wants to continue to support others if she decides not to breastfeed, or if the baby passes. So, being able to support parents in that as well. And then this is for the Center of Advancement of Palliative Care. These are the recommended diagnoses for a perinatal consult. So you'll see our genetic conditions. We see quite a bit of trisomy 18 in our work. We mentioned cardiac conditions earlier with acardia, single ventricle physiology. So that's that hypoplastic left heart, hypoplastic right heart, different kidney problems. You guys can kind of peruse through those diagnoses. And then we also have ones that aren't mentioned here that they may be like 1 in 5 in the world that might have this. So we have also seen that as well.
Okay, so, we don't want you to feel like that palliative care is all sad or, or hard things. We also actually support families in hope. And so we're going to take just a brief detour. So the purpose of palliative care is absolutely not to take away hope. From I don't know that there is actually any other medical literature that would have a definition for hope included. But you can see from here in our literature, hope is defined as a positive expectation that goes beyond visible facts. It's a concept of greater than mere expectation. It's a motivating force. It actually assists in finding meaning in life. It's a reflection of what's most important to a family, a way to endure and cope with suffering. And it's actually a way to support decision making. When I meet with a family and they tell me, well, I hope the doctors are wrong. I hope that what they're seeing will change, and I hope that my baby will be born and be healthy. I don't tell them, well, that's not going to happen. I tell them, and I honestly, my hope for them is, I hope you're right, and I hope for those things too. but my medical brain worries that perhaps, that's not going to happen. And so how do we support you if that's not the case? A parent has said, my job was to have hope and be a positive influence. So we don't want you to think that palliative care is about taking away a family's hope. But we do help families to reframe that hope. So again, in that situation where they're hoping that that what we're seeing will not come to pass, or our worries won't come to pass, we'll ask them, well, given what we are seeing, given what our worries are, what are the things that you're hoping for your child and for your family? And most of the time, again, that's for a cure or for options to prolong their child's life. In our work with families, meeting them before baby is born, sometimes that hope is that, I just hope that the baby survives to delivery because I want to meet my baby alive. Or for dad, for siblings, for extended family to meet the baby. Sometimes they talk about, I hope for a peaceful death. Sometimes it's that they hope that they're able to hold their child when their child dies, and for their child not to be hooked up to machines, if that's the case. They hope for the best quality of life possible. There's a quote here from a family that they said, they hope that their baby lives a long time, but we know that she probably won't. And when her time comes, we just hope she doesn't suffer. In another one of my perinatal visits, I had a dad that told me that he hoped he would be strong enough to let his baby go if it got to that.
So a couple other things to consider to support the family. So this is all about memories. So really, we encourage, take pregnancy pictures, take a special trip, take baby Edward to San Francisco, take baby Edward to San Diego. And even though baby Edward might not be born, that's a way of honoring their life. We will tell families that you can sleep with a special blanket that might be like home, smell like home. So when baby is born, they have a familiar smell, and you're able to wrap them up in that blanket so they know what home would be like. Medicine has come so far, and now we have really cool 3D and 4D ultrasounds. So really, encouraging that as well. And then recordings of heartbeat. So we use this a lot, and this can be just used off of a Doppler and somebody recording, their heartbeat on an iPhone. We have bears from Build-A-Bear that we sometimes will also, record their child's heartbeat into, and then we'll place them in a bear for the family to have. So just things to think about, because what a powerful thing to have, even if they don't make it to delivery, or even if they don't survive birth, that they would, have that as a beautiful memory. And then different things that parents can do to make memories with their child once they're born. So hearing the first cry, having family come and visit with them and their baby, like we talked about earlier. Sometimes it's, I really want my mom to meet my baby. I really want my dad to meet. I really want, her brother to come in. And, so really being able to honor that time. And then being able to parent a baby. So, I think about parenting, and I think about, don't climb up the stairs or don't eat that, but really just, letting them bathe their child, letting them put clothes on their baby, like letting them hold their baby. When we do our birth plans, we talk about medical interventions at time of birth, and sometimes all parents want is to just hold their baby and not have any sort of medical intervention unless it's absolutely necessary. And we encourage that, because that takes that time away from mom and baby. And then providing comfort from pain. You know, we have a lot of families express that. And then, you know, taking their baby outside is a big one. And then, you know, sometimes we have families that, you know, make it to discharge from the hospital and they come to our inpatient hospice unit, and we can put holidays together for them. So, you know, Christmas and Halloween and everything, when we know their life might be limited, to celebrate those milestones with families. So this is one of my, I feel if you don't take anything else away from this PowerPoint, I really hope that you do take this slide away. So what does it mean for those of us who care for these babies and their family? So I'm just going to go through the needs and then kind of tell you a little bit of a story about myself. So need to understand the policies and protocols of your specific institution. Need to be comfortable with the fact that your patient may not live beyond birth. Need to be in touch with your own feelings regarding mortality. Need to realize that families' values may be very different from your own values, and their decisions may be very different from your own decisions. And need to support team members and especially take care of yourself. So a little bit about me. I came to fall in love with comfort care after I was an adult ICU nurse for about 8 years. For 5 of those years, I worked at a hospital in Boston that had a pretty high mortality rate. And, you know, we were either doing these very high-tech interventions like ECMO or CRT, or we were providing very intensive end-of-life care. And I fell in love with the end-of-life care piece. I fell in love with being able to support these families during that time. And when I moved back to Phoenix, I knew that my passion was to be in palliative care and hospice. I remember when I very first started thinking and meeting patients, and that was my job. I was an admission nurse, so really bringing patients onto hospice and admitting patients onto hospice. Thinking about my own mortality and thinking, oh my gosh, like, would I make this decision for myself? Would I pick this for my loved one? And that was a tough 6 months. And then, you know, I realized this is not about me. I am not here to pass judgment. I am not here to make these decisions. You know, these families have been through so much, and then to realize that you are the person that's there to support them is really special, to be a part of that journey, because it's such a special journey, and it is one of the biggest honors of my life that I think of now is supporting pediatric patients, supporting these moms, and certainly supporting these perinatal children. So I think it goes with saying the famous quote, you know, people will never remember what you say, but they will always remember how you made them feel. So just take that with you. And, you know, sometimes these babies are born and they live for 3 minutes, and sometimes they're born and they live for 3 hours. And you being a bedside nurse, or you being that lactation consultant, or you being the bedside physician, you can make that journey just so beautiful for them. And remembering that that might be the only life that that child ever has. So just making sure to, if you do have a judgment, just being kind and remembering that these families have had a really hard road up until this point. So,
But in addition to that, it's also, you know, we recognize it's hard to be the person at that bedside.
Especially,
yeah. And so making sure that you take care of each other and take care of yourself, so that, you know, you can continue to do the amazing work that you do.
And the hard work.
Okay. We didn't want to send you away without any resources. So first, we have these bereavement resources. There are resources both for families, and then there are resources listed here specifically for our siblings or younger family members. So there's the New York, and some of these actually have links to different organizations or different resources as well. So they're just a starting place for you. There's the New York Life Foundation, Courageous Parents Network, which was actually started by a bereaved family. There's ULUNA, which is a national bereavement support organization and programs. We love this book for our families. It's called This Little While. It really helps them to process and go and move through their grief. It's also available in Spanish. Again, for our siblings or for our younger family members, Sesame Street and Communities. And another book that we really love, especially for these perinatal situations, is We Were Going to Have a Baby, but We Had an Angel Instead.
So back to baby Edward that we kind of introduced in the very beginning. So family was the 28-year-old Native American woman, and was, for those of you that may have joined later, mom was pregnant with a child with trisomy 18, and this little one had both brain and cardiac anomalies. So we were able to bring them onto our perinatal program, and our social worker was initially able to introduce the program and really found out that they were really on that road towards comfort care. So we brought them into Ryan House, and Billy, myself, our social worker, and Erica, our family support counselor, were able to meet with baby Edward's parents and talk about everything. I mean, we sat in that room for 2.5 hours talking about, you know, this family was so very special, and we just kept hearing over and over the common theme was, we just want to honor him. We want to honor him. We want to meet him. You know, and that was their biggest concern. So we had a really nice time meeting with them and speaking with them and going through that. Sorry. We also, you know, parents also shared that the biggest priority for them was to focus on mom's health. So making sure that, you know, if it needed to happen, that she would go for C-section to make sure that she stayed healthy. We were able to complete the birth plan with them, which what was the most important, what we kind of said before, is finding out their hopes was that they wanted family members to be at the hospital to meet baby Edward. And this was in 2021, so it was still kind of heightened COVID time, so we were able to get those exceptions. And because they were Native American, they had rituals that they wanted to do, and we were able to make plans for those as well. And we did talk about memory making in detail. Now I lay me down to sleep, I believe, went to the hospital and got pictures. And then we talked about keepsake and care, different type of cares. So they were able to make it to discharge. So they had said, you know, if baby Edward is, you know, healthy enough to make it to discharge, then we would want him to come to Ryan House, which is our pediatric inpatient unit for hospice. So about 24 hours later, mom was safe for discharge as well, and they were able to be admitted over at Ryan House. Family was in, all of family was there. And they were at Ryan House for about 2 hours and never left parents' arms, which was really special. We were able to do a lot of memory making with them. We recorded some heartbeats, and it turned out to be a beautiful ending to that journey.
And it just so happened that that day we were here for a meeting. And so all the people that had been at that meeting before Edward was born, we all got to meet him. And it really was like, I feel like for them coming home to meet friends and not being sent into, sent to strangers.
Yeah.
Some resources for you. So in addition to supporting families, we want to make sure that you also know where you can go for more information. So there is a national, or there are national and international lists of programs. So you can look and see if there's something available in your community. If not, perhaps there's someone nearby, or maybe you want to start your own program. There is a training through Columbia University. Our team is actually going to attend this a little later this month, and so we can let you know how it goes, but I hear very good things. And there's an International Children's Palliative Care Network, which gives or has some e-learning courses for you available.
Thank you so much.
Yeah.
If you ever have any questions or you want to shoot us a question, please take down our emails. Those are our emails, and we're always happy to answer anything. And this is definitely our passion. So please feel free to reach out if you ever think of something and you wanna ask. So
absolutely. And I hope that we accomplished our primary goal, which was really to make all of you champions of palliative care. So please select a specialty.
Yes, select a specialty. And then we would love to open for questions. I think we have 15 minutes exactly. So we would, any questions we would love to answer.
Thank you, Dr. Weingart and Amanda, for that great presentation. It reminds me, I kept thinking of this over and over during your presentation of the Welcome to Holland essay or story that was written by Emily Pearl Kingsley, I believe it was, where she talks about parents or a mother excited about planning a trip to Italy. They've planned for months and months, and the day finally arrives, and after the plane lands, they hear an announcement, "Welcome to Holland." So their dreams of being in Italy were changed by landing in Holland, and how they were able to embrace being in Holland. It was just a really neat story I remember hearing several years ago. So everyone, I'm sure, that comes in contact with you appreciates the work that you're doing, and it takes a special person. I can see you guys both really care for your patients that you come in contact with. So thank you again for presenting for us today. We do have about 15 minutes for questions. So anyone who has a question, please use the questions panel to submit those. The first question is, how does genetics affect the ability to donate organs or tissues?
So I think in that it would depend on the purpose of that donation. So there are many, through our organ procurement organization, there are gestational age requirements as well as weight requirements or size requirements for to be eligible for donation of either organs or tissues. And sometimes those babies just will not make it to that to those thresholds. And so we actually do have options for families to donate for either research or for education, which actually we're a group from Phoenix Children's are presenting a poster at the American Academy of Pediatrics conference about how that donation actually helped a family to process their grief.
Okay, thank you. The next question is, what are some talking points you may use when parents change their mind at the last minute from comfort care to full code status?
We have had that situation. We have families that actually have gone or changed goals back and forth. I think it's, this decision is the hardest that we could ever ask a family to make. And so I think it's just, acknowledging that with families and having that conversation, and, that we know that this is so very hard for you, and I think just being there and I think doing our best to not try not to make them feel judged for making that change.
Absolutely.
You know, when we go through a birth plan, I always tell the families that, you know, nothing is written in stone. They could be driving to the hospital or, you know, being wheeled into the, you know, the OR for a C-section, and they can say, you know, that stuff we wrote down, never mind, you know, because we always want them to feel like, you know, that they have options and they can make those very hard decisions.
We've had people flip the other way too. We've had families that we've met with that have shared, you know, that they want everything done. And then we hear later that baby was born and that they chose comfort care. So I think it's, or like Billy shared, it's an impossible position to be in, and just making sure that they feel supported is the best. So,
yeah.
Thank you. The next question is, how do you suggest the best way to address lactation? Do we initiate or help with stopping milk production?
I think that that's very family dependent, because there are some, again, you know, that they know if they continue to pump, that they can donate that breast milk to help other babies, to help other families. You know, it couldn't help their baby, but, you know, they see this as part of their baby's legacy. There are other families that even prenatally, you know, before baby is born, they're asking, well, how do I stop my milk production? And so I think it really is just, again, letting them know the options, normalizing both. You know, a lot of times in that we will talk about, you know, there are some families that make this decision, and there are other families that make this decision, and there are families, you know, in between. So how can, you know, what is most important to you, and how can I support you in that?
Thank you. There are a couple questions that came in regarding the Roe versus Wade repeal. I don't know if you could speak to that, but there are a couple questions pertaining to that.
I think we're at a place right now where everything happened. It feels like it happened a while ago, but it still feels fresh. And I think we're at this point where I think it's really too soon to tell with how things are going to go.
Yeah.
And I think really just, you know, supporting those patients and having, you know, them lean on their medical team, and really, you know, providing them that emotional support. But I think it really is too early to tell with a lot of that.
Okay.
I think, you know, it may limit families' options or take away that option of terminating a pregnancy, but we don't know kind of the more downstream effects of that, at least not yet. But I don't know, do you want to share the questions and see if we
Can help.
Because they were both kind of the same, I just kind of lumped them together.
Okay.
I can certainly provide those to you both after, and you
Okay.
can.
Sure.
Okay, perfect. Sorry about that.
No, you're fine.
The next question is, can they donate the body to science?
Yes.
So we've had a few families. No one has donated their baby's entire body, but we've had some where, again, baby may have a cardiac anomaly that may actually impact lungs. And so we've had a few families that have donated heart and lungs to Phoenix Children's. We've had families that have donated their baby's brain to the NIH to help assist in their research. You know, it really is, if that's important. So that's why we talk about that when we're going through a birth plan, is really to find out what are the family's goals, and then we can find out what options are available to help support those. I think we've both been in the situation of, where it hadn't been discussed, and then after the child dies, family brings up the idea of donation, and there just isn't enough time to coordinate that. And so then we have to, unfortunately, tell them that we're just not able to help them or support them in that goal, which is why, we think it's so important to include. But, there are national organizations that appreciate any of those donations. They're just so meaningful to help in furthering medicine.
Thank you with that. The next question is, how can medical students learn more about palliative care works in their potential specialty choice, i.e. peds versus emergency medicine versus internal medicine?
So I think the road to palliative care, different people get there in very different ways. For me personally, I went to medical school, I became a pediatrician. I thought that actually I would do pediatric oncology, but I realized that, what I really wanted to do was just care about my patients and care about their families. And so I realized that the specialty that really allowed me to focus on caring was palliative care. And so right after my my residency, I went straight to fellowship in hospice and palliative medicine. But you could go, from internal medicine, you could go from family medicine, you could go from emergency medicine. When I was we had a fellow one year that her background was obstetrics, but she wanted to be a hospice medical director. And so the road to palliative care, really, you can go through just about any other specialty. It really is about, do you want to focus more on kids or adults, or, really, what kind of background do you want? And there are also many people that palliative medicine may be a second career for them, that, they have been in the ICU or they've been in the emergency room, and, something about the care that's provided there may not seem to fit with what they think is most important anymore, or they want to go to that place where, they want to have the time to really care about their patients and their families. And so then they may transition to palliative care. I don't know if that answers that question.
That sounds like it did. Thank you. There was a question that came in. I'm not sure if you would know the answer to this, but do you know of suggestions to use breast milk in making a memory like jewelry or something like that?
Yes, I don't have a resource right off the top of my head, but I could get it to you after. But they do have, we should have included that. I'm so sorry. We should have included this. There is a way to make breast milk into jewelry, and I don't know exactly what it looks like, but I hear it's beautiful. We actually, a level 1 trauma center that my child life specialist and I went to earlier this week, and we were doing some memory making education with their ECMO team. They had mentioned that one of their patients who had passed was a new mom, and they took the breast milk and they made it into something. So I will get that information for you.
Perfect. And I will provide it to everyone that's on the call.
Yeah, for sure.
Let's see, there's a lot of questions coming in. I'm trying to keep up with them. Quite a few saying not specific questions, but thank you. It takes very special people to help these families. Thank you for a wonderful presentation and all you do for parents. No question, but thank you so much. I've learned so much, and I will bring this back to my team and families. The world is lucky to have you two in it. Let's see. Oh, there's a lot coming in.
Appreciate you guys.
Yeah, we really appreciate being able to be here. So thank you all.
See. Oh, and it looks like we're almost at the end of the time. If any other questions come in that need to be answered, I will pass them on to both of you. Thank you again so much for presenting for us today. And just a couple quick things before we end. We are at the top of the hour already. It did go fast, but the registration for our October 12th webinar is open. So you can visit medelaeducation.com for more information and to register for that. And certificates will be available this Friday by logging into your account. And after we end this webinar today, a separate window will open up with a evaluation. So if everyone can fill that out, that would be greatly appreciated. And I hope everyone has a great afternoon. Thank you again for joining us today.
Thanks,
Thank
everyone.
you so much.
Thank you.